The broadcast is now starting. All attendees are in listen-only mode.
Hello, this is Gary Swartz with the American Academy of Home Care Medicine. Thank you for joining us this afternoon. Hopefully the weather where you are, your patient condition and coverage arrangements are lining up such that you'll be able to enjoy the upcoming holiday weekend. We want to review this afternoon a fraud and abuse primer. The webinar objectives are to provide an overview of federal fraud and abuse laws and regulations, overview requirements for Part B service and documentation, reference the compliance plan requirements and CMS Getting Started checklist that is now available on the CMS site and part of the webinar materials, reference the resources that are available to you, the home care medicine services and compendium of federal regulations, upcoming fall webinars, the Academy 2015 annual meeting, and the CMS materials referenced this afternoon will be posted with the slides on the sites, on the Academy site, and leave times for your questions. As mentioned, the Academy is produced by Home Care Medicine Services and Compendium of Federal Regulations, Medicare Part B coverage, payment, and compliance. That's available if you don't have it yet. It's available for purchase and relates to this afternoon's materials and good for your practice operations and planning and compliance practice development. So first we want to begin with talking about the drivers of scrutiny in the area of fraud and abuse. These aspects include the national, local, political mood, pressure and scrutiny regarding government performance that we are seeing continuously in the press. Growth in federal programs continues, the ACE with the ACA, exchanges in the states and on the federal level, Medicaid expansion that has come along with that, and also the continued growth in the Medicare Advantage portion of the Medicare program. At the same time, we have the budgetary pressures and the requirement of the government to reflect return on investment in terms of its investigations of fraud and abuse in healthcare and in other areas as well. Recognition that the Medicare program benefit design has historically and in some cases continues to be subject to exploitation and to those with criminal intent. And then we also have new services developed recently and proposed for 2015. And there's limited experience base both within CMS with these services and across Part B providers. And these services are the transition care management services, mobility devices, care management services that's proposed for 2015 as well. Drivers of fraud and abuse, again, the scrutiny, why you may experience scrutiny. Your services in the home include relationships to other parties that are under scrutiny, home health agencies, durable medical equipment, suppliers, etc. There's a history of fraud and abuse of other healthcare fields and parties that provide services in the home. The development of shared savings programs may present potential conflict of incentives. There's an increased attractiveness of home care medicine providers due to the care you provide and the financial impact you produce. So you may be hopefully receiving the positive interest of an increased number of suitors and then with resultant transactions and increased complexity of those transactions. As we know, there's a shortage of home care medicine providers, and that makes, again, those of you on this call and those of you supporting your practices on this call attractive in terms of service and the compliance that you reflect. Again, there's new services with limited and experience base, as mentioned. Takeaways from this afternoon. I want to provide an increased level of awareness of the areas of fraud and abuse and federal regulations and related aspects. I want you to be able to to go from this webinar to be able to ask questions regardless of where you are in practice, whether it's solo practice or large practice, what other extent of relationship developments and transactions you may have underway or may be coming your way. Enhance that feeling, that sense that if something is too good to be true, if you're being asked to participate in a relationship that does not seem right, well then it may well in fact be too good to be true. If another party is hesitant in terms of the relationship development, understanding services or the value in the transactions you're trying to achieve or recommended, there may be a reason. Want to provide a baseline to provide enhanced efficiency for you with local advisors, your accountants, attorneys, consultants, etc. In other words, want you to be able to manage your cost for yourself and for your practice. Want to provide a context as you set out to render the new services, to the background and backdrop to their documentation, and to submit the claims for services now being covered or that will be covered in the future. Again, transition care management services comes to mind, as well as the evolution of shared savings programs. And we will see this more in the code descriptions in the final rule later this fall, and as part of the requirements for documentation and coverage and claim submission in 2015. And again, you may experience medical record review request as a result, and again, this is all going to be part of a learning experience by CMS as well. Also want to mention that I often see reference to excluded providers in the OIG materials that the Office of Inspector General materials that the Academy reviews, and want to again heighten your awareness to make sure of those that you're interacting with or considering for your practice, that you conduct that due diligence or relationships that you may be entering, etc., and those involved to be aware of not being involved with excluded providers. And there is the opportunity to review that on the OIG site. What concerns CMS in a somewhat increasing level of increasing level is the error, incorrect coding, and erroneous payment. That's considered to be about the 10% level, and there are multiple programs that CMS conducts to reduce its amount of incorrect or erroneous payments, and they, as an agency, are under scrutiny by OMB and the OIG to become more efficient in their analysis and payment systems. Waste, claims, and payment for medically unnecessary services, abuse, and proper billing practices, for example, upcoding, and then finally fraud, billing for services or supplies that were not provided. And then ultimately they are, CMS that receives pressure from the public and from Congress. Next we want to review the outline of what the federal laws are governing Medicare fraud and abuse, the False Claims Act, anti-kickback statute, physician self-referral law, also known as the Stark Law for Congressman Stark of California, with the original legislation, other provisions of the Social Security Act, and the United States Criminal Code. And violations of these laws may result in non-payment of claims, civil monetary penalties, exclusion from participation in federal health care programs, and criminal and civil liability. An important takeaway is that there are situations where liability can exist without proof of actual knowledge or specific intent to violate the law. What is the general landscape? There are federal and other payer considerations. These laws impact or apply to Medicare, including now the shared savings programs, such as accountable care organizations, the Medicaid programs, Medicare Advantage health plans have an increasing set of fraud and abuse oversight and evaluation programs focused on their operations, Part D drug benefit programs and plans. You should know that in your states across the country there are what's known as mini fraud and abuse or mini Stark laws, and that's why as you interact with counsel and consultants on a local level, you want to have any transactions reviewed both from a federal perspective and also on a state and local perspective. Then I also want to mention something that is we increasingly are contracting with Medicare Advantage plans and also state managed care organizations or health plans that are involved with the duals and Medicaid programs, that there are provisions there that would bring about contract law considerations. This could include secondary payer requirements and the requirements to submit claims to the other payers first, or to collect deductibles, et cetera, and then co-payments, et cetera, for the private insurer to, in a sense, stand in your shoes and pay or stand in the patient's shoes, that is, and pay for your services. Also want you to be aware, for those of you who are considering or already rendering concierge or private pay types of services, that you want to scrutinize any of your health plan agreements to review provisions. If any of those patients or health plan members are members of health plans, what provisions may govern responsibilities and obligations there, and any opportunities or restrictions of opportunities for concierge or private pay services. There are exceptions or safe harbors to these fraud and abuse regulations. They also exist by statute and regulation. The exceptions, safe harbors from one set of laws, well, they apply to one set of laws, the False Claims Act, the Anti-Kickback Statute, Stark, etc., but they do not provide you with the exception safe harbor from another set of laws. So you must analyze the situations under each set of laws to make sure that the relationship you have under development, being planned, considered, comports to with each sets of regulations. The False Claims Act. The False Claims Act actually deals with more than just health care. It's from the Civil War, so it's not new. It's intent-based. It protects the federal government from being overcharged or sold substandard goods or services. It imposes civil liability on any person who knowingly submits or causes to be submitted a false or fraudulent claim to the federal government. Be aware the knowing standard includes acting in deliberate ignorance or reckless disregard of the truth related to the claim. In other words, we can't have our heads in the practice sands, if you will. We have to be aware of what's going on in our practices, and we can't say that claims are submitted by others or by third parties, and feel that obviates our need to, our obligation to know what's being submitted for the services that we render. And the civil penalties may result, including fines, and there's also a criminal False Claims Act component as well. False claim examples include billing for services that were not medically necessary, charging excessively for services or supplies, misusing codes on a claim such as upcoding or unbundling codes. Again, in review of materials that we see from the enforcement agencies, this seems to be the number one area of the cause of issues related to services in the home environment are in the false claims area. And again, also often involvement of excluded providers. And again, I just want to mention that because I'm seeing a lot of that in the in cases. So recommendation to avoid deliberate ignorance or reckless disregard from your perspective. Want you to be contractually and from a practice perspective and a pragmatic perspective, assure yourself that the practice that you're involved in, your own practice or those within which you practice or considering providing your professional services has implemented a compliance plan, and that the compliance is established through practice culture and operation as well, and is well embedded and upheld by the leadership and throughout the organization. I want to make sure that you are assured of your own knowledge of coding and compliance is adequate to document and code, and also to question that of others or those who are doing coding for the entity, to assure that your knowledge is adequate to question policies and procedures or the lack thereof that you see in place, that you obtain for yourself the right to review claims that are submitted with your name, NPI attached, regardless of whether the claim submission process is internal, that is the revenue cycle process, and claim submission is done by yourself, your own practice, or that's outsourced to a billing vendor, and they also have compliance plan obligations as well. Also want you to assure yourself protection for any internal disclosures through compliance mechanisms that are developed in the practice, and then also avail yourselves of external opportunities as well if your observations and concerns are not recognized within the practice. In this area, we have seen situations where providers have participated in agreements where a contract may have said how its codes or how the provider claims are going to be coded, regardless of how the provider actually documented and coded the claim themselves. And even if their counsel or others, or if they didn't read that provision or paragraph of the contract, again, that would not remove themselves and protect themselves from the requirement of that they should have known, and the responsibilities under the False Claims Act. Again, another practice situation, also the provider claims were changed, encoding were changed after the fact, and the providers there did not insist that they have an understanding, or in the sense your own auditing of from time to time of how your claims are being submitted. In your relationship to the practice, if you're operating the practice, if you're in an LLC or partnership situation, or regardless of the legal entity, again, also want you to contractually and pragmatically assure yourself that the practice has implemented a compliance plan and that it is established, again, through culture and operation. Your knowledge of coding and compliance is adequate to document and code and to question policies and procedures, that you and your relationship to the practice and governance and ownership have a right to review claims that are submitted with the practice name and TIN associated, and again, in an ownership role or in a management responsibility, you will have, again, heightened responsibility for those submissions. That there's a right to discipline or terminate clinical and non-clinical staff who are not compliant. And again, there's protection for internal disclosures and in external disclosures as required. That you've established protection from practice partners who are not compliant, and protection, again, from third-party vendors and others who are rendering service in the home who may not be compliant as well. And again, what can happen is that an entity can be taken down by the actions of a few that may not be known to others but should have been known to others, and in an environment where our services and practices are increasingly getting involved in larger organizations and being acquired or developing practice relationships we have to make sure that that in practice from a legal perspective and a financial perspective and also public relations and marketing perspective, and what we'd want to see in the paper or not see in the paper the next morning is appropriate in the way it should be. The federal anti-kickback statute relates to governs illegal remuneration, also known as the anti-kickback statute. Makes it illegal for any person to knowingly and willfully solicit or receive any remuneration, and the various types are described there, in return for referring an individual for goods or services payable under a federal health care program, including Medicare and Medicaid. And again, the penalties follow on the slide. This could be in situations where patients, providers receive something of value in exchange for the ability of the other party to submit a claim. We see that in the DME situations. We see that in home health, et cetera. And some of the services are rendered in real, and some of the services don't even exist. The anti-kickback statute in practice, just how to think about it, is the patient going one direction and remuneration going the opposite direction. Those of you on the call, and essentially you could cross your arms across your chest and point your fingers in opposite directions, and if one arm and hand and finger is the patient going one direction, and if there's value or remuneration coming the other direction, then you may have absent an exception or safe harbor a problem in that situation. Case law, beginning with Katz of maybe perhaps 15 or 20 years ago, established a standard that even if only one purpose of the agreement is for remuneration, then the statute is violated. In other words, there can be many good reasons that an overall relationship is established. It could be for quality reasons, efficiency, market size, scale, a geographic opportunity, et cetera, convenience. Everything might make sense, but yet the statute will be violated even if just one purpose is found to be the exchange of remuneration for referrals. And again, it does not have to be the primary or the largest reason for the agreement. It just has to be one of them for the relation to run afoul of the anti-kickback statute. Some examples of remuneration could be cash, could be agreements beyond the market value for services, reduced rent. There's been question if a practice is situated in a relationship with a facility, an inpatient facility or a home health agency. Can that be accepted, et cetera? There could be remuneration that could come through support for infrastructure, system support. There is a safe harbor for EHR that was developed to support the adoption and uptake of electronic health records. But I want you to be aware of all the different ways or aspects of remuneration could be considered. One thing that I saw, that it could be staffing by an organization. This wasn't necessarily for a home care medicine practice, but a lab services organization provided its technicians that were on its own dime, if you will, or payroll, to a practice for draws and support with patients, and yet let the practice bill for those services as if those services were part of the practice, and yet that was lab organization staffing, and in exchange what they got were the lab specimens, of course, and the ability to submit claims to the Medicare program. So again, get a sense of heightened awareness. This could be through referral programs as well. patient services coming out of discharge planning into the community, etc. So some areas of scrutiny again. This is more on the relationship development side and acquisition. So if you're being, if you have the opportunities to be engaged in discussions about the acquisition of your practice or discussing the acquisition of other practices, some areas that the OIG has its own heightened awareness about is payment for goodwill, the value of ongoing business units, covenants not to compete, exclusive dealing agreements, and what that means is where value in the transaction would be placed on the covenant not to compete, that would be outsized or larger than it should otherwise be for the value of the practice relationship, and it's just a way of finding a way to basically to pay for the referrals of the practice by finding a place in the agreement to locate those payments. So that would be in the covenants not to compete. This is again what would be subject to scrutiny or exclusive dealing arrangements, payments for patient lists, payment for patient records, etc. Additionally, the OIG advises through prior letter advice, if the economic position of physicians or providers is expected to significantly improve as a result of the acquisition, then it may be that purpose of the acquisition is to can offer remuneration for the referrals which the physicians or practice can make to the buyer. What is, again, good, and this goes back to that even if one purpose of the payment could be considered or construed for or is documented for the referral relationship, some things that may fall under scrutiny, divergence programs. We see a growth of our urgent care centers, diagnostic centers that are more convenient, lesser cost than emergency rooms, convenient for the ambulatory practice, but also being considered for those in the home care medicine, home limited patient environment. And if there was ownership there, then it could raise question about you have the patient relationship, and yet you're sending them to an entity in which there's ownership, etc. Again, not saying that there is anything wrong in it or that cannot be again comported into the fraud and abuse regulations. Just saying where some scrutiny may come up in some evolving areas. Practice evaluation is payment for system referrals or for your community population health management and admissions reduction. We see on the hospital side there's increasing number of diagnostic codes for which hospitals are going to be penalized up to a total of 3% in the aggregate. In the teens going forward, starting in 2017, more services, cabbages, for example, are being added to that diagnostic list. And our understanding that for good reasons that hospitals are reaching to community providers, post-acute parties, and providers such as academy members to assist them with their readmissions reductions. But again, in your discussions with systems or health plans about becoming part of that health plan or being acquired, you want to keep these things in mind. Also, practice valuation is payment for post-acute service development and efficiency. Those of you being approached by home health agencies, et cetera, or is that for services for which a claim can be submitted, such as the ability for the certifications of home health services, et cetera. So again, some things to again for heightened awareness.